Chronic obstructive pulmonary disease. Etiology. Tobacco smoking is responsible for 80% of the risk of developing chronic obstructive pulmonary disease, COPD. Other common risks include occupational exposure to environmental dust, e.g. coal miners, organic antigens, e.g. farm workers, and alpha-1 antitrypsin deficiency. Smokers vary in their susceptibility to COPD, only 15 to 20% developing clinically significant disease. Pathophysiology. COPD is characterized by airflow obstruction that is usually progressive, not fully reversible, and does not change markedly over several months. Airflow obstruction is due to a combination of airway and parenchymal damage that result from an abnormal inflammatory response of the lungs to noxious particles or gases. It also produces significant systemic consequences. Epidemiology. The prevalence of COPD among adults is approximately 4 to 6%. Clinical presentation. COPD is frequently diagnosed as a result of recurrent respiratory infections or exertional dyspnea, an incidental finding during medical assessment for other reasons, e.g. elective surgery, or during a GP screening of smokers. Patients presenting with polycythemia, cor pulmonale, or respiratory failure, although this is rare. Physical signs. May be none in the early stages, but look for prolonged expiration, signs of hyperinflation, bilaterally reduced breath sounds, and widespread wheezes. In instances of advanced disease, look for use of accessory respiratory muscles of the neck and shoulder girdle, paradoxical inward movement of the intercostal muscles on inspiration, Hoover's sign, expiration through pursed lips, cyanosis, cor pulmonale, and weight loss. Investigations. Spirometry. This is essential for establishing the diagnosis and assessing the severity of COPD, Table 24. Airflow obstruction is defined as a reduced forced expiratory volume in 1 second, FEV1, below 80% predicted, and a reduced FEV1/forced vital capacity ratio below 70%. NB. Spirometry is the only method of early diagnosis of COPD in asymptomatic patients and should be performed in all patients over the age of 35 who have a risk factor, generally smoking. Always confirm clinical suspicion of COPD by spirometry. Do not rely on peak expiratory flow, which in COPD may be misleadingly high while FEV1 is already significantly reduced. Reversibility testing. Not necessary in most patients, as a response to long-term therapy is not predicted by acute reversibility testing. Over-reliance on a single bronchodilator reversibility test may be misleading unless the change in FEV1 is greater than 400 ml. Oral corticosteroid reversibility is no longer recommended, as it does not predict response to inhaled corticosteroid therapy. Chest radiograph. Conduct to exclude other pathologies that can mimic COPD, e.g. signs of hyperinflation, increased lung height, flat diaphragm, increased retrosternal airspace and narrow heart shadow, parenchymal areas of hypoattenuation and bully, Fig 19. Blood tests. Perform FBC to identify polycythemia. Measure alpha-1 antitrypsin level if early onset, and take a minimal smoking history or family history of COPD. Arterial/earlobe gases. Perform if FEV1 is 92% and there are signs of right heart failure or respiratory failure in order to assess the indication for long-term oxygen therapy. Body mass index. Decreasing body mass, observed in 20% of patients with severe COPD, is associated with increasing mortality. Transfer factor for carbon monoxide. Check if the patient's symptoms are disproportionate to the spirometric impairment. High-resolution CT scan. A CT scan of the chest should be performed if symptoms are disproportionate to the spirometric impairment, if there are unexpected abnormalities on the CXR, or to assess suitability for surgery. ECG and echocardiogram. If features of cor pulmonale are apparent. Differential diagnosis. A major differential diagnosis is asthma, and this should be considered if a patient shows an exceptionally good response to treatment. Serial domiciliary peak expiratory flow measurements may be required if diagnostic doubts remain. Other common conditions presenting with similar symptoms, signs, and spirometry include bronchiectasis, congestive cardiac failure and lung cancer. Bear in mind that as well as mimicking COPD, these conditions may also coexist in a patient with COPD. Emergency treatment. NB. If a patient with known COPD looks very ill or worse, give high-flow oxygen to buy time for rapid assessment and instigation of ventilatory support. As stated before, hypoxia kills. Hypercapnia merely intoxicates. Management in a less severe case comprises the following. Oxygen, in patients who are not about to die, controlled oxygen, starting with 24%, given via a humidifier, is administered according to arterial blood gases, aiming to bring the SaO2 above 92%. Arterial blood gases should be rechecked within 60 minutes of starting oxygen therapy and again within 60 minutes of a change in inspired oxygen. Humidification is important in order to decrease mucus plugging. Bronchodilators, Nebulist B2 agonist, e.g. salbutamol 5 mg, an anticholinergic, e.g. ipratropium 500 microgram, repeated as necessary. NB. Patients with asthma or COPD produce thick viscous secretions that significantly contribute to airway obstruction and are difficult to clear. Humidification of air/oxygen is simple, has no adverse side effects and helps greatly, so do not forget it. Steroids, start oral, e.g. prednisolone 30 mg OD, or intravenous, e.g. hydrocortisone 200 mg QDS, steroids. Antibiotics, amoxicillin 500 mg TDS will usually be given. Diuretics may be helpful if there is any evidence of fluid overload. Physiotherapy, to help with sputum expectoration, but will not be helpful if the patient has a very tight chest and is not coughing anything up. If the patient does not improve with instigation of these treatments, then seek help sooner rather than later. Nasal intermittent positive pressure ventilation and/or continuous positive airway pressure may be necessary, and endotracheal intubation and mechanical ventilation will be indicated in some patients. Decisions about such escalation of treatment are not straightforward. If confronted with a moribund patient in whom a decision has not already been made, then the default position must clearly be to proceed with treatment. However, no effort should be spared in discussing management with a respiratory physician if circumstances permit, preferably one who already knows the patient. Treatment of stable patients. Smoking. All patients regardless of age should be encouraged to stop smoking and offered help, e.g. nicotine replacement therapy, bupropion, and smoking cessation clinics, at every opportunity. Inhaled therapy. Short-acting bronchodilators, B2 agonists and/or anticholinergics. Initial treatment, as required, for the relief of exertional dyspnea. Long-acting inhaled bronchodilators, B2 agonists and/or anticholinergics. If symptoms persist despite the use of short-acting bronchodilators. Inhaled corticosteroids. Prescribe as follows. A trial of 6 weeks to 3 months should be offered to all patients to identify those with airflow limitation responsive to inhaled corticosteroid treatment. If there is no improvement in symptoms or airflow obstruction, inhaled corticosteroids should be discontinued. These should be added to long-acting bronchodilators to decrease frequency of exacerbations in patients with FEV1 less than 50% predicted, who have had 2 or more exacerbations requiring treatment with antibiotics or oral corticosteroids in a 12-month period. NB. Maintenance use of oral corticosteroid therapy in COPD is not normally recommended. Theophylline, slow-release formulations. This should only be considered after a trial of short-acting bronchodilators and long-acting bronchodilators. Mucolytic therapy. Consider in patients with a chronic productive cough. Continue if there is symptomatic improvement, e.g. reduction in frequency of cough and sputum production. Pneumococcal and influenza vaccination. This should be offered to all patients with COPD. Nutritional supplementation. For malnourished patients. Antidepressant treatment. Depression should be considered in patients who are hypoxic, SaO2 92%, have severe dyspnea or are admitted to hospital for exacerbation of COPD. Pulmonary rehabilitation. This should be offered to all patients who consider themselves functionally disabled by COPD. Long-term oxygen therapy. Indications for long-term oxygen therapy. Chronic hypoxemia due to COPD, chronic asthma, diffuse parenchymal lung disease, bronchiectasis, pulmonary vascular disease, cystic fibrosis, idiopathic pulmonary arterial hypertension, pulmonary malignancy, and heart failure. Nocturnal hypoventilation due to obesity, neuromuscular disease, chest wall disorders and obstructive sleep apnea. Palliative use. Patient selection. The need for oxygen therapy should be assessed in all patients with cyanosis, patients with polycythemia, patients with cor pulmonale, edema. In COPD, patients with a forced expiratory volume in 1 second less than 30% of predicted. All patients should be on optimum treatment prior to assessment for long-term oxygen therapy, LTOT. LTOT is indicated in patients with daytime PaO2 less than 7.3 kPa on 2 occasions, 3 weeks apart during a period of clinical stability. Daytime PaO2 7.38.0 kPa, in the presence of cor pulmonale, edema, polycythemia or nocturnal hypoxemia, SaO2 less than 90% for more than 30% of the time. Once a patient fulfills the criteria for LTOT, the appropriate flow rate that can achieve a PaO2 more than 7.3 kPa should be determined by checking the arterial blood gases on oxygen. In the NIH NOT trial, the majority of patients needed 1 TO2L/min of oxygen delivered by nasal cannulae. Patients will need an additional 1 L of oxygen during exercise and while sleeping. Ambulatory oxygen. All patients with chronic lung disorders should be assessed for ambulatory oxygen requirements. The 6-minute walk test is a simple and widely used stress test that makes it possible to evaluate the functional status of patients with lung disorders and their ability to carry out activities of daily living. The test measures the distance walked on a flat surface in 6 minutes and requires a constant level of effort similar to that needed by the patient to carry out activities of daily living. The test has also been used to assess exercise-induced desaturation. The American Thoracic Society guidelines for domiciliary oxygen state that ambulatory O2 should be prescribed to patients normochemic at rest with evidence of exertional desaturation to 88% or less. Short-term ambulatory oxygen is associated with significant improvements in health-related quality of life. Ambulatory oxygen can be prescribed in 3 groups of patients. 1. Patients on LTOT who are mobile and need to leave the home on a regular basis. 2. Patients on LTOT who are housebound and unable to leave the home unaided, but may use ambulatory oxygen for short, intermittent periods only. 3. Patients without chronic hypoxemia but who show evidence of arterial oxygen desaturation on exercise. Short burst oxygen therapy. Short burst oxygen therapy, SBOT, is commonly prescribed for patients who do not fit the criteria for LTOT but remain breathless after minimal exertion. It is usually provided from cylinders. SBOT either before or after exercise probably does not benefit the majority of patients with moderately severe COPD who exercise for more than a very short period of time. Modes of administration of oxygen. Oxygen cylinders. Oxygen concentrator. Portable small lightweight cylinders for ambulatory oxygen delivering liquid oxygen. Non-invasive ventilation. Indications: acute respiratory failure leading to respiratory acidosis. This may be due to exacerbation of COPD, cystic fibrosis, or bronchiectasis, or pulmonary edema or pneumonia. Patients with one of the above conditions may develop acute respiratory failure and respiratory acidosis, pH less than 7.35 with raised PaCO2. Chronic respiratory failure, patients with neuromuscular and chest wall diseases, obesity, hypoventilation syndrome, obstructive sleep apnea with hypoventilation, COPD with hypoventilation and, in fact, any respiratory disorder with hypoventilation may not be able to breathe out carbon dioxide, causing respiratory acidosis. Initially this occurs during the night and can be detected by overnight monitoring of transcutaneous carbon dioxide. Measurement of arterial blood gases at 7 a.m. is also helpful as it reflects nocturnal gas exchange. Such patients may also complain of morning headaches due to raised PaCO2. Nocturnal NAP can improve their gas exchange and symptoms. With disease progression, their need for NAP will increase. Contraindications: respiratory arrest, inability to use a mask because of trauma or surgery, excessive secretions, hemodynamic instability or life-threatening arrhythmia, high risk of aspiration, impaired mental status, an uncooperative or agitated patient, life-threatening refractory hypoxemia. Complications: ulceration of the nasal bridge due to a tight mask. This can be avoided by choosing the correct size mask and applying gel foam at pressure points. Gastric distension, hypotension, barotrauma. Practical details: if NAP is indicated, it should be started as soon as possible. Delays due to non-availability of a bed are unacceptable, as respiratory acidosis worsens with time. Before starting NAP in a patient with acute respiratory failure, decide whether the patient will be a candidate for intubation and mechanical ventilation should NAP fail. If so, the intensive care unit (ICU) team should be informed as early as possible. The initial IPAP and EPAP should be set up as per the hospital guidelines. Once NAP is started, measurement of arterial blood gases should be repeated in approximately 1 hour, earlier if there is clinical deterioration. If there is an improvement, treatment should continue on the same inspiratory and expiratory pressures. If PaCO2 is increasing, IPAP can be increased to help blow it off. If arterial blood gases are improving, they should be checked at increasing intervals. Once the acidosis is corrected, NAP can be stopped. However, if this occurs in late evening, it will be prudent to continue NAP overnight and stop it next morning. Always remember to optimize medical treatment for the underlying condition. Though NAP may be effective in respiratory acidosis due to exacerbation of asthma, such patients should be managed in an ICU with access to immediate intubation. Surgery. Bulectomy. For breathless patients who have a single large bully on a CT chest scan and FEV1 less than 50% predicted. Lung volume reduction surgery. Consider if the patient is experiencing marked restrictions in activities of daily living despite maximal medical therapy, including rehabilitation, if FEV1 more than 20% of predicted, carbon monoxide transfer factor more than 20% of predicted and PaCO2 less than 7.3 kPa, and if there is upper lobe predominant emphysema. Complications. Common, infection, bacterial and viral, and side effects of corticosteroid treatment. Uncommon, pneumothorax, cor pulmonale, and respiratory failure. Prognosis. In general, this is inversely related to age and post-bronchodilator FEV1. The 5-year survival rate in patients admitted with a hypercapnic exacerbation is 28%.